ACE inhibitors are an exciting class of medications which have been used since the early 1980s. These medications work by blocking a chemical which causes spasm in both the arteries and veins of the body and lungs. By blocking spasms in the vessels of the body, it reduces blood pressure not only in the body but also blood pressure within the lungs. Since ACE inhibitors lower the resistance to blood flow, they maintain or actually increase the amount of blood pumped by the heart. This is how they improve the flow of blood to the muscles and organs of the body. ACE inhibitors also have a direct action on the kidneys, which reduces the work of the kidney filters. This is particularly important when it comes to diabetes. The two major reasons that diabetics frequently develop kidney failure is overwork of the kidney filters and high blood pressure. Since ACE inhibitors lower blood pressure and reduce the work of the kidney filters, they tremendously reduce the risk of developing kidney failure in diabetes. There are at least 8 ACE inhibitors. They can be divided into short-acting ACE inhibitors and the long-acting ACE inhibitors. The short-acting ACE inhibitors include Capitan or Captopril and Acupril, also known as Quinapril. The remainder of the ACE inhibitors are long-acting, with Vasotec or Enalapril being the one with the most clinical usage and research proving that it works. There are many advantages to ACE inhibitors. The first is that they are very well tolerated. That is, they do not produce very many side effects. Furthermore, the long-acting ACE inhibitors are very convenient to take since they only need to be taken once or twice a day. Another advantage of the ACE inhibitors are that interactions with other medications are uncommon. The major exceptions, however, are lithium and rarely with digoxin and arthritis medications such as aspirin or ibuprofen. The other major advantage with ACE inhibitors is that they have proven to be effective in multiple studies to prevent kidney failure in diabetics. It has been known for years that when diabetic patients start spilling a lot of the blood protein albumin in their urine, the kidneys will fail usually within 5 to 6 years. This must be treated with dialysis or kidney transplantation, or death will occur. Kidney failure will develop in 40% of those who have diabetes for more than 20 years and approximately 60% of those who have diabetes for over 30 years. ACE inhibitors can significantly reduce the spilling of albumin in the urine and help prevent the kidneys from going bad in patients with diabetes. A 5-year study was conducted by Dr. Ravid and his associates in 94 patients with type 2 diabetes, that is, the type of diabetes that does not require insulin. None of these patients had high blood pressure. Half of the patients were given Enalapril or Vasotec 10 milligrams per day, while the other half was given a placebo. This figure shows the amount of albumin spilled in the urine in a 24-hour period of time in the two groups. It is obvious that the Vasotec reduced the amount of protein spilled in the urine, and the difference between the groups which received Vasotec and the group that received the placebo increased with time. At the end of the study, kidney function deteriorated 13% in the group who received the placebo, but remained stable in the group who received the Vasotec. This figure shows the clear worsening of kidney function with time in the group who received the placebo compared with the group that received the Vasotec. The results of this study have been confirmed in at least 20 other studies using Enalapril and other ACE inhibitors such as Captopril and Lisinopril in diabetics that use insulin or in diabetics that do not need insulin. For these reasons, many physicians recommend that virtually every diabetic patient should be placed on an ACE inhibitor unless there is a specific reason not to use them. In addition, all diabetics should have their urine checked yearly for the presence of albumin. By checking the amount of albumin in the urine, we can tell whether or not the kidneys are being adequately protected. Ideally, the amount of albumin in the urine should be less than 30 points in a 24-hour period of time. The proper dose of ACE inhibitors to prevent worsening kidney failure may vary in different patients. The studies with Enalapril or Vasotec use 10 milligrams per day. The studies with captopril used 25 milligrams 3 times a day. A recent study looked at the amount of ACE inhibitor and the amount of albumin in the urine. It showed the greater the amount of ACE inhibitor used, the greater the reduction in the amount of albumin in the urine. For this reason, most people think that diabetics should eventually receive at least 10 milligrams of enalapril per day or 25 milligrams of captopril 3 times per day if tolerated. After several months, a 24-hour urine albumin check should be done. If the albumin is greater than 30 milligrams in 24 hours, the dose of the ACE inhibitor should be increased if possible, and every effort should be made to reduce the top number of blood pressure to less than 130. The amount of protein in the urine should then be rechecked and additional therapy provided as tolerated. The ACE inhibitors are usually started in low doses, such as 2.5 milligrams of enalapril once a day in diabetics who have low blood pressures or in diabetics who have bad kidneys to start with. The dose is gradually increased at weekly intervals with careful monitoring of kidney function and potassium level until 10 milligrams per day is used. In diabetics who have high blood pressure and normal kidney function, higher doses, such as 5 milligrams twice a day, can be used initially. Let's now cover the side effects and disadvantages of ACE inhibitors. The most common side effect is cough. This will occur in approximately 3% of patients who take ACE inhibitors. Another side effect is an increase in blood potassium level. This occurs in up to 2% of patients with diabetes. A third side effect is worsening of kidney function. This occurs in 1 to 2% of patients with diabetes and can be quickly reversed in most patients by reducing the dose of the ACE inhibitor or stopping the ACE inhibitor altogether. The fourth side effect is lightheadedness and occurs in about 5% of patients who have low blood pressure before they are started on the ACE inhibitor. Due to these uncommon side effects, we routinely recommend that approximately 1 week after starting an ACE inhibitor or 1 week after changing the dose of an ACE inhibitor, that blood tests be performed to check kidney function and potassium levels. Furthermore, if a person is on an ACE inhibitor and is also started on an arthritis medication, such as aspirin or ibuprofen, we also recommend that within 1 week a blood test be performed to assess the effect on kidney function and potassium levels. These blood tests are performed to ensure the safety of the ACE inhibitors. If abnormalities in blood potassium level or kidney function occur, simply stopping the medication or reducing the dose will reverse abnormalities and in general prevent any permanent damage. If cough prevents the use of an ACE inhibitor, a new medication called losartan or Cozar can be used as a substitute, since it acts just like an ACE inhibitor but does not cause cough. The final question is, how long should you take an ACE inhibitor once it has been determined that it is appropriate for you to take them? Unless significant side effects develop, such as kidney failure, high potassium, very low blood pressure, or severe cough, the ACE inhibitors should be taken until age 95. At age 95, you can stop all medications and have a party. The bottom line, though, is that you should take these medications as long as they are tolerated and as long as you want to stay off dialysis. I hope this educational video has helped you understand the importance of ACE inhibitors in the prevention of kidney failure in diabetes.